Good morning to my senior colleagues and dear resident doctors. My topic for today's talk would be pulmonary function and reserves in CLD. So initially I would be talking briefly about pulmonary function methodology, then pathophysiology and research studies. Reserves in CLD, I couldn't find any direct studies. The reserves would be detected by indirect methods. So pulmonary functions Pulmonary function tests are critical diagnostic and monitoring modality for individuals with respiratory disease. Conventional PFTs have been used to measure the pulmonary function of patients with liver cirrhosis, and alterations may be present in approximately one-third of patients with decompensated liver cirrhosis and with additional abnormalities in PFT and diffusion in as many as 50% of patients with liver cirrhosis. So what are type of pulmonary function tests? Traditionally and most commonly used is spirometry, lung volumes and gas exchange testing, that is DLCO, maximum voluntary ventilation, inspiratory and expiratory muscle pressures, 6-minute walk test. Other unconventional tests are methacholine challenge test, cardiopulmonary exercise testing, fractional exhaled nitric oxide, that is FeNO, impulse oscillation or forced oscillation test, compliance testing, high altitude simulation testing and oxygen titration test. So PFTs are valuable tests for evaluating symptoms of dyspnea. They have to be interpreted with a systematic approach. While PFTs provide a pattern of physiological impairment, but they do not make a diagnosis. A normal PFT can be found in patients with asthma and vice versa. Also, a abnormal PFT can also be there in normal scenarios. So this is a very classical curve depicting lung volumes and capacities. Initially when patient is asked to breathe normally, this inspiration and expiration, this is called tidal volume. Beyond the tidal volume, when patient is asked to take a deep breath, then tidal volume plus inspiratory reserve volume makes a inspiratory capacity. After inspiratory capacity, when patient is asked to forcefully exhale, then patient beyond tidal expiration, patient exhales to the functional residual capacity, which is a combination of expiratory reserve volume and residual volume. Combination of inspiratory capacity and functional expiratory volume constitutes the forced vital capacity, and total lung capacity is inspiratory capacity plus functional residual capacity. So this is what the graph we traditionally see in the spirometry testing. On the x-axis is the flow in liters per second versus the volume in liters which is exhaled. It is plotted against the flow in liters per second. Initially there is a expiratory phase on the upside, followed by a declining curve. So this curve also sometimes gives us the information if in the COPD or smokers, this scooping out of this curve is suggestive of early obstruction. Similarly, the lower curve, the volume in liters is plotted against time in second, and FEV1 is the forced expiratory volume which is exhaled in the first second of breath. So what does PFTs measure? The tidal volume, minute ventilation, vital capacity, functional residual capacity, residual volume, total lung capacity, forced vital capacity, forced expiratory volume, forced expiratory flow, peak expiratory flow rates. Patterns of disease with PFT, it could be obstruction when the absolute value of FEV1, that is forced expiratory volume in first second, to the total forced vital capacity, if either it is less than 0.7 or less than lower limit of normal, which is found in asthma, COPD or other bronchiectatic condition. Restrictive defect is there when total lung volumes are low, FVC is low, even FEV1 is low. Found in interstitial lung disease, neuromuscular weakness, pleural disease, chest wall deformities, obesities and the ascites. And finally, there could be mixed pattern consisting of both obstructive and restrictive elements. When to ask this spirometry, when patient is having more than 40 years of age, have a smoking history, they feel breathless, frequently coughing, and concerned about the lung health and are already diagnosed with lung condition. What are contraindications and main reasons to avoid testing? Major thoracoabdominal surgeries, brain, eye, ear, ENT surgeries, pneumothorax, myocardial infarction, ascending aortic aneurysm, hemoptysis, and for the CLD patient, equivalent is hematemesis, which is also an absolute contraindication for doing pulmonary function testing. Pulmonary embolism, acute diarrhea, angina, severe uncontrolled hypertension, confused dementic patients, discomfort, and infection control issues like with COVID and TB and many other infections. So these are some are relative contraindications, while myocardial infarction, ascending aortic aneurysm, they are absolute contraindications. What are the bedside pulmonary function tests which we can do? Sabrace's breath holding test. In this test, one can ask the patient to take a full but not too deep breath and hold it as long as possible. So if this breath holding test patient is able to hold beyond 25 seconds, then it is indicative of normal cardiopulmonary reserves. In between 15 to 25 seconds, they are limited cardiopulmonary reserve, and if patient is able to hold the breath for less than 15 seconds, they are indicative of very poor cardiopulmonary reserves, and they are make relative contraindications for elective surgery. So there is a rough estimate of the breath holding time and the vital capacity of this patient or the patients. We have done limited ILBS data on CLD patients who are being evaluated for liver transplant. So, of the 10 patients we have done, we could see that their average age is less than 50 in most of the cases. The breath holding time is still less than 20 and less than 23 seconds in 2 out of 10, that is 20%, and compromise in many other patients. So let's come to pathophysiological mechanisms for PFT changes in patients with liver cirrhosis. There is a component of reduced lung compliance and restrictive defect because of these following factors, that is ascites, atelectasis, pleural effusions, encephalopathy, respiratory muscle weakness, hepatic hydrothorax, obesity, inflammation, and insulin resistance. Further, in many of the studies, small airway dysfunction, that is defined by forced expiratory flow between 75% and 25% exhalation of vital capacity, and an increase in closing volume, which may be due to either intrinsic alterations in small airways, that is muscle edema, muscle spasm, or changes in transmural pressures of the airways because of peribronchial and interstitial edema, which is present in CLD patients because of decreased colloidal oncourt osmotic pressure, impairment in lymphatic drainage, or altered permeability of pulmonary vasculature. About the gas transfer impairment in CLD patient, there are many factors which are affecting this DLCO. One is intrapulmonary vascular dilatations, widespread interstitial lung illness, ventilation perfusion mismatch, pulmonary veno-occlusive diseases, and perfusion diffusion imbalance, which is a scenario which is present because of intrapulmonary shunting. There is a lung segment which is ventilated as well as perfused, but that is not effective because of the larger diameter and shunting that is not ventilated. One of the commonest abnormality which we see in the ABGs of the patient is hyperventilation, respiratory alkalosis, and decreased partial pressures of carbon dioxide, which are related to hyperammonemia, ascites, hepatopulmonary syndrome, increased chemosensitivity to carbon dioxide and hypoxia, and poor progesterone and estradiol metabolism. So, spirometry determines the maximum amount of air that a patient can inhale and exhale while exerting maximal effort. Calculating volumes or flow as a function of time. Variations in the values of FeE1, FVC, peak expiratory flow rate, FE, forced expiratory flow rate 25 to 75% have been described in these liver cirrhosis patients. Many of these studies are reporting obstructive dysfunction, many are describing obstructive as well as restrictive abnormalities, and some researchers have identified isolated abnormalities in FEV1, FVC, peak expiratory flow rates and mid expiratory flow rates. Pulmonary function testing in children with liver cirrhosis is showing the similar kind of data with limited studies which are done. Some are showing obstruction or restriction, isolated declines in FEV1, decreased DLCO values. But alteration in PFT values have not been related to either duration, histological severity or grading or fibrosis in children with liver cirrhosis. What is diffusion capacity for carbon monoxide? Diffusion capacity is the volume of any gas that diffuses across the alveolar capillary membrane in 1 unit of time per minute and with 1 unit of pressure gradient, that is per unit of mercury. DLCO per unit volume, on the other hand, is diffusion capacity of 1 liter of lung volume. Decreased DLCO and decreased DLCO per unit volume have been reported in patients with liver cirrhosis. So how DLCO is measured, a word about that. Using the following techniques, DLCO can be measured: single breath method, intra-breath method and rebreathing technique. What we are following in our institute and most commonly followed is the single breath method in which patients are initially asked to take normal resting breaths followed by exhalation up to residual volume. The patient is then asked to rapidly inhale the test gas up to vital capacity. The test gas contains very small quantities of carbon monoxide, that is 0.3%, 0.3% of other tracer gases like helium, methane or neon, 20%, 21% of oxygen and balanced nitrogen. Patient is then asked to hold his breath for 10 seconds at total lung capacity. Subsequently, patient exhaled out completely and exhaled gas is analyzed for carbon monoxide and other tracer gases. Total lung volume, initial and final carbon monoxide concentration and breath holding time are used to calculate DLCO. So both DLCO and DLCO per unit volume of lungs have been shown to negatively correlate with child score. DLCO per unit volume has also been shown to exhibit a negative correlation with MELD score. In addition, DLCO has been found to exhibit a significant positive correlation with serum albumin and cholinesterase level, that is higher serum albumin, higher DLCO, that is more normal lung, and negative correlation with, of course, with progressing CLD because of esophageal varices, ascites, and negative correlation with ventilator time, ICU and hospital stay of staying following liver transplant. Also with heart-liver ratio in thallium scan per rectum scintigraphy, which indirectly also indicates portosystemic shunt in advanced disease. This now I will share a PFT report of the patient. So this is kind of a spirometry report we have for the patient. It is showing FVC, forced vital capacity, FEV1 by FVC. This ratio, FEV1 by FVC, absolute ratio is shown here. That is the best value for the patient. It is now, we can see 86.1%. If it is less than 70%, then it is obstructive, and more than 70%, it could be normal or could be restrictive. Other important parameters are peak expiratory flow rates, and for other parameters it is the percentage predicted which is taken, and for the FEV1 by FVC this absolute ratio is taken into account. One more parameter is maximum mid expiratory flow rate between 75 and 25%. So in this case all of the parameters are normal, percentage predicted, and by FEV1 FVC it is 86, which is more than 70, so it is likely showing normal. For the same patient now we have done DLCO testing. So in the DLCO testing, the initial value is absolute DLCO ml per minute per unit of mercury of carbon monoxide. So which is now we can see is 58%. So DLCO, normal DLCO is either less than, more than 75% of predicted or more than LLN. Between 60 to 40% it is moderate diffusion impairment. So in this case, as DLCO is 58%, we will label this report as a moderate diffusion impairment, while per unit volume it is normal. So In such type of scenarios, when spirometric values are normal and there is isolated diffuser impairment that is of moderate grade, then this kind of PFT testing should suggest us towards a abnormality like hepatopulmonary syndrome, and we should reflexly test for saline contrast echo for IP shunting. We don't have this saline contrast echo report for this patient till now. Conditions affecting DLCO, there could be increased DLCO after exercise in supine position, after some maneuvers, pulmonary hemorrhages, polycythemia, left to right shunt, obesity, asthma, chronic bronchitis in the morning in the pregnancy. While decreased DLCO values can be seen post exercise, standing, Valsalva maneuver, lung resection, emphysema, vascular disease, ILDs, anemia, evening, and some drugs. Maximal inspiratory pressures and maximal expiratory pressures are used to measure the respiratory muscle strength at the amount a patient can exert. It is measured in the centimeters of water. So inspiratory maximum pressure is a predictor of weaning success from mechanical ventilation, and expiratory maximum pressure is a predictor of effective cough. This is one study on dyspnea and respiratory muscle strength evaluation in end-stage liver disease patients. So they have segregated these all patients into ascitic and non-ascitic groups. Now we can see the expiratory maximal capacities and inspiratory maximal capacities are higher in non-ascitic patient versus ascitic patient, and also they have reported absolute values are lower than the normal, which are significant. And respiratory muscle strength parameter is also deduced from the equation from PE max and PI max. It is also higher in non-ascitic patient. So, and it is also correlating with dyspnea score, that is MMRC score, which is not significant between ascitic and non-ascitic groups. So chronic dyspnea correlates with respiratory muscle strength in all patients. This correlation in subgroup of patient without ascites is close in subgroup of patient without ascites. Now a word about nitric oxide synthesis. Nitric oxide is synthesized in body from L-arginine by nitric oxide synthase, which is present in three forms, that is neuronal nitric oxide synthetase, a inducible form which is there in the respiratory epithelium, that is NOS2, and endothelial nitric oxide synthetase, that is NOS3. Understanding the cellular sources of fractional axial nitric oxide and its role as a biomarker in type 2 inflammation. Although this gas was invented for the diagnosis of allergic airway, it is present normally for the normal physiology in femtomolar and picomolar concentration. This nitric oxide regulates the tone of airway, regulates pulmonary blood flow, bronchodilation, surfactant production, regulation of permeability of alveolar capillary membrane, stimulates the ciliary beat, anti-inflammatory effect, mediated local immunity process and neurotransmission. While there is a increased production because of inducible nitric oxide and the concentration rises to nanomolar, then the same gas start producing negative effect in the form of bronchial hyperreactivity, mucus hypersecretion, vascular permeability, vasodilation, pro-inflammatory effect, inhibition of ciliary motility, production of free radicals, and cytotoxicity. Nitric oxide produced at femtomolar to picomolar level is fundamental for respiratory physiology, and nitric oxide is produced in large quantities by airway bronchial epithelial cell upon regulation of INOS. Increased NO production is pro-inflammatory and induces bronchial hyperreactivity, mucus hypersecretion, and increases vascular permeability. So NO can be measured in axial air as a fraction of axial nitric oxide. It is a robust marker of airway inflammation that indicates type 2 inflammation, and increase in expression of T2 inflammatory cytokines like interleukin 4, 13 lead to overexpression of INOS and consequently to an overproduction of airway nitric oxide. Endogenous pulmonary nitric oxide production estimated from axial air is an increase in individuals with cirrhosis and liver failure. there is a significant negative correlation with pulmonary vascular resistance, that is higher levels of NO are correlated with a decreased pulmonary vascular resistance, decreased DLCO, average O2 consumption and heart rate reserve, while it is positively correlates with alveolar arterial oxygen gradient, that is if there is a higher nitric oxide production because of advanced liver disease, there is an increased alveolar arterial oxygen gradient. Also with the cardiac index, ascites, portal vein thrombosis, mucosal red color sign of varices, a high HUPG and childhood score are also positively correlated with FeNO. So there is this study by Christopher Dikelux. They have estimated nitric oxide fractions, that is alveolar nitric oxide at 200 ml per seconds breathing exhalation rate and 50 ml per breathing exhalation rate. So in healthy control, we can see the FeNO values at 50 ml is 15.9, at 200 is 7.4 and alveolar is 4.7. Now if we compare them with those of liver cirrhosis, smoker and non-smoker patient, the average FeNO levels are higher as compared to healthy persons. If we see these same levels in the asthma patient, which are most of them non-smokers, the average FeNO levels are higher in asthma as compared to smoker, to the liver cirrhosis patients also. In the same study, they have reduced this fractional exhaled nitric oxide from alveoli, a level of 7.5 parts per billion is an exhaled nitric oxide at 200 ml per second of 9.5 is a cutoff criteria that can define patients who are hypoxemic to the non-hypoxemic patients who both are having cirrhosis. So inhaled nitric oxide improves the hepatopulmonary syndrome, a physiological analysis. In this study, they have evaluated patients with various interventions. One is positional effects. In the supine versus seated position, there is an increase of absolute change in PO2 of 3.3. In Trendelenburg position versus supine, it is 0.9. With methylene blue, it is 1.1 and 2.3. But with inhaled nitric oxide, there is an absolute increase of 12.4 mm of Hg with this inhaled nitric oxide. Addition of methylene blue to the inhaled nitric oxide doesn't affect much of change. So, percentage of patients who incur more than 10% and more than 20% of increase in PO2 is highest with inhaled nitric oxide and with significant values. So they have reduced inhaled nitric oxide, significantly improved partial pressure of O2, that is 12.4 mm Hg with significant p values without deleterious effects on cardiac outputs. One more study on respiratory muscle strength, hypoxemia and dyspnea and liver cirrhosis patient is in non-ascitic versus ascitic. There is a difference in PO2 which is higher in non-ascitic group, MMRC, inspiratory maximal and expiratory maximal capacities and respiratory muscle strength which are significant. Influence of ascites on pulmonary function in patient with portal hypertension. In these studies, they have measured this spirometric values pre-ascitic tap and post large volume paracentesis tap in this 20 patient. So in pre-tap, when spirometry criteria was labeling them as COPD in small airways, post-treatment also COPD in small airways. Some of the patients have changed their category from COPD in small airways to normal COPD in small, nil to nil, mild to normal, moderate COPD to the mild COPD and so on. In the same studies, pre and post-tap, they have shown that there is a significant increase in FVC percentages, FEV1 and FEV1 percentage as well as PaO2, significant increase in PaO2 decrease in PaCO2 and saturation after these large volume paracentesis. So this gives an idea of how results are compromised because of ascites in CLD patients. One more test which I could find is this labeled phenylalanine breath test in aged patient with chronic liver disease. So in this study they have made the patient to orally intake 100 milligrams of this labeled phenylalanine, and then they have estimated, because of this phenylalanine is converted to tyrosine and there is CO2 production. So they have estimated the CO2 production in these group of patients, chronic control patients which are normal, chronic hepatitis B and CTP A, B and C classes. So what they have shown is that CO2 production is highest in response to this labeled phenylalanine, highest in normal patient, and it decreases with the child A, B to C classes, which is also a PFT, but it is determining the liver functions or state of liver. Now this is the limited data of a study of effect of large volume paracentesis on bedside measures of lung function and subjective dyspnea and fatigue scale from our department. Now in these we have measured SpO2, MMRC, respiratory rate and numeric dyspnea and numeric fatigue scale pre and post large volume paracentesis. So we can see there is an improvement in MMRC of at least 1 grade, saturation of around 1 to 2% average saturation increase. There is improvement in numerical dyspnea scale and fatigue scales and respiratory rate as well. Evaluation and comparison of spirometric lung functions and diffusion capacity assessment of cirrhosis patient. This is from our institute, it is under publication. So we have evaluated this spirometric lung functions in CLD patients. Those CLD patients were compared with the healthy liver donor population. So as we can see that as compared to healthy liver donor population, the CLD patients, the absolute values are reflecting the minus or plus strongly as compared to healthy liver donor population. We can see there is a significant decrease in FeV1, FVC, FeV1 by FVC ratio, maximum mid expiratory flow rate in all classes, even in post liver transplant patient in CLD patients who are evaluated for transplant and who are evaluated for otherwise. So in this study, in our retrospective study of large subjects, this study not only confirms the presence of predominant restrictive ventilatory defect but also has unraveled high prevalence of a small airway limitation and very high prevalence of diffusion impairment in cirrhotic patient versus background prevalence in apparently healthy liver population. So the mean FeV1, FVC, FeV1 by FVC and maximum mid expiratory flow rates were all significantly lower in cirrhotic patients. So if we can see, the normal lung functions are present in only up to 50% of patients. Thank you. I was junior resident. We didn't have pulmonary technician at BHU at that time. So residents were only doing sleep studies and PFT.